Our next speaker will be Dr. Luisa Galvis. And sorry, Dr. Galvis, if I pronounce a few of the words in your bio and I botched them. So, Dr. Galvis is originally from Medellin or Medellin,
That's perfect.
Colombia. Oh, perfect. Colombia, graduated from the Faculty of Medicine at Universidad del Antioquia in 2008, worked as a general practitioner in a rural community, and then completed her intern medicine residency to the same faculty as the Hospital of San Vinci de Paul in 2009 to 2012, and worked as an internist and adjunct professor for 2 years in the Clinica Leon Tresi. She then completed 2 years residency program in the medical oncology of Instituto Nacional de Patología, Universidad del Bosque, Bogota, Colombia. She was awarded a scholarship to complete her fellowship in thoracic and gastrointestinal oncology at l'Hôpital Charles de Moyne with Université de Sherbrooke in 2017. She has been working at the medical oncology as in Dr. Everett Chalmers Regional Hospital in Frederick, New Brunswick since 2018, where she is now the division head. Her professional interests includes lung, gastrointestinal oncology, immunotherapy, patient-oriented research, and advocacy. To you, Dr. Galvis.
So thank you for inviting me. So I'm one of the medical oncologists in Fredericton, New Brunswick. We are actually currently just three of us, but trying to get more people to join. So I'm going to try to share my screen. So you will give me a couple of seconds here. There. Okay. Perfect. So I was invited here to present some things about the advances in lung cancer screening for this interesting symposium. So again, thank you for inviting me. And so these are my disclosures. I do consultant and speaker work for a few companies, and as you mentioned, I have had been awarded with grants for clinical trials or for my own training from pharma companies, but I do not believe there is a conflict of interest for this talk in particular. So just to let you know that lung cancer accounts for basically 1 in 5 cancer deaths. This is worldwide. So if you see the red lines here, about 20% of the cancer-related deaths are because of lung cancer. So this is a real problem worldwide. Remember, cancer is the #1 cause of mortality in Canada, and lung, of course, is the first like cause of cancer-related mortality as well. So that's above colorectal, liver, breast, stomach, pancreas. You could say like you could put them all together and still lungs is the king. Unfortunately, is a deadly disease. So for 2025, and this is from Statistics Canada, like more than 30,000 Canadians are going to be diagnosed. And this is about 13% of all new cancers. From those, about 20,000 people will die from lung cancer, and it represents more than 20% of all cancer deaths. So that means on a daily basis, we get 85 Canadians who get the diagnosis of lung cancer per day, and 56 who are dying per day. So that's a big number that we have to deal with, and is not going to necessarily go down unless we intervene drastically. So that's why I guess lung cancer matters because, again, it's the most commonly diagnosed cancer in Canada, is the leading cause of death from cancer for both men and women. So even though there is some decline in the rate since 2015, and this is probably related to some control to the smoking programs that are out there, the lung cancer still kills more people than breast, prostate, and colon cancer combined. So lung cancer is a big problem. It's like for sure the major cause of mortality in our society. So that high rate of mortality is related to the time at which the cancer is diagnosed. So if you see here in this graph, what I'm showing, it has different colors and it shows from stage 1 to stage 4. So if you see this lighter green is the stage 1A, which is a very early diagnosis for this type of population. And if you see in the years from diagnosis, those people about more than 80% could be alive at 10 years if you get the diagnosis around that early stage. In contrast, if you go to the stage 4A and 4B, which is the purple colors, so for that population, in spite of treatments, unfortunately, we have that around 5 years, less than 10, like 5% will be alive. So that means that it's a deadly cancer for sure, but it has some hope the earliest we can get to it. In between, there are the other stages, again, stage 1B, 2A, 2B, and 3A, 3C. That depends on the number of lymph nodes involved, the size of the tumor, and so on. So there is a variety of expectations in terms of survivals, and it depends on the original staging of the tumor. So that's where getting ahead of the diagnosis or trying to find it earlier makes a whole of a difference in terms of the mortality. So again, here in New Brunswick, so we already talked about worldwide. I also talked about Canada, but then let's come here home in New Brunswick. So New Brunswick is the lung cancer is the leading cause of cancer-related death. So again, cancer is the #1 cause of mortality in New Brunswick, and the leading cause of cancer-related death is lung cancer here. So that would be 800 new lung cancer cases are diagnosed, and 600 lung cancer deaths are expected per year. So that represents 1 out of 4 cancer-related deaths. And most of the diagnoses, unfortunately, are done in the stages 3 and 4. So if you remember from those curves I just showed you, most of these populations that we get to diagnose, they are in those later stages. That's why it's so deadly, because we find it late, basically. So the promise of early detection kind of tries to give us some light around the possibility of treating and maybe getting a better survival, even if lung cancer is still there. So the reason why this is feasible or is possible for lung cancer is that there is usually a long preclinical phase before there are symptoms that appear. This is specifically in a subtype of lung cancer. Not all the subcancers or the subtypes of lung cancer are the same, but the majority of them, they do have this preclinical stage where people do not have symptoms, but if we find the cancer early enough, it could be treated. And therefore, this is why screening is important. You may have already known, or you are already aware of the screening programs, for example, for breast, that has mammogram every year or every couple of years, and then you have the occult blood in stools, which is the screening test for colon cancer, or the implementation of colonoscopies for colon cancer as well. So the triage in lung cancer just basically looks into trying to find the lung cancer before it is too late or before it is already spread. So that's basically what I'm going to talk about. And just to, again, call the attention about how important this topic is imagine that we are having in New Brunswick basically once per year an Airbus A380 or a Boeing 747 being crashed. Every year in New Brunswick, that's the amount of people who are dying from lung cancer in our province. So it's not something that happened to others. It's not something that is rare and is not very close to home. Like, this is basically what is happening. If we turn on the TV and we saw that there was an airplane crash every year in New Brunswick, that would be a major situation. Like, everyone would like to intervene about that, or no one would like to take an airplane for sure in New Brunswick. But this is what is happening with lung cancer here. So this analogy I actually learned it from one of my the professors who work with me back in Montreal, and it always stuck into my head. Like, this is the amount of people who die from lung cancer is as big as a crash of an airplane, and this is exactly what is happening here in New Brunswick. So the screen modalities are different. They have tried different strategies. So we have, for example, the cytology on the sputum. So that will be more of for people who have already some sort of cough or some sort of symptoms. We can get the sample and look for it in the laboratory. We can also use chest X-rays, and then the other part is the low-dose CT. So when they have been compared to each other, the one that seems to be the one to use is the low-dose tomography. Why? Because it's more sensitive than the other two. The other ones are actually less effective. They will miss a lot of the cases, so they are not recommended currently for doing the screening process. But the low-dose CT will be the preferred method. So the idea of this method will be to detect small nodules, and therefore, if we are able to find out if they are actually cancer, then they will be treated, and under this lens, it will reduce the lung cancer-related mortality and also may encourage smoking cessation. So keep in mind that my talk is about screening, but I cannot just leave out of the message that smoking or the intervention in smoking cessation is also very important to any reduction that we want to do in mortality for lung cancer. So the low dose tomography is basically the modality of choice when we want to do a screening for lung cancer. And if the question will be like, if this is such a good tool, why don't we use it regularly for everybody? So we cannot do that because there are some risks that come with screening themselves. So they are very well known from other diseases, again, like breast cancer, like colon cancer, but it's not different for lung cancer. So when we have false positives, so that for sure will increase like those false alarms. Like people, there is some stress that comes with it. It comes with unnecessary follow-ups and procedures that will just give burden to the system that you know already that is quite to the limit. So there is this factor of the expenses that come with given an intervention that is not tailored, like the whole population having, for example, low dose CT scans that wouldn't be feasible. And also for people who are having these false positives, they will have anxiety related concerns with that. When we end up having invasive procedures like biopsy just to confirm, because this will be just a screening, but we always need confirmation, there are always risks that come with biopsies. There are also complications that come from unnecessary interventions. And of course, the more we do CT scans, the more exposure we have to radiation, and there always comes a risk of secondary malignancies to radiation exposure. So, screening is not without any risk, but of course, is necessary when what we are facing is the major cause of mortality worldwide, and of course in New Brunswick. So in order to support the modalities of screening, we have a couple of trials. One is the Nelson trial, and the other one is the NLST. So they had about 50,000 participants, and they were showing, especially people who were higher risk. So that would be people who have a smoking history, as well as other criteria. So they will apply regular low dose tomography, and that alone in the NLST reduced the mortality by 20% in that population in the follow-up in 5 years. There was a high rate of false positive, but the complications were actually low and rare. By the Nelson trial, we know that there is a 24% mortality reduction in men and up to 48% reduction of mortality in women. This is as a follow-up of 9 years. So this is basically what supports the decision and the need to have a screening program in place everywhere. Because it does support that it's an early detection. It will pay down the road, right? So basically, what we can do once we have a positive finding, so this is the NLST, which is the National Lung Screening Trial. And what they will do once they have a positive test, they may need to do either a needle biopsy or a bronchoscopy or a thoracotomy even, or mediastinoscopy. So if you see, those are interventions, and they will see, like, okay, from those interventions, what were the complications that appeared, and then if there were some related deaths to that. So again, as I mentioned, there was a high rate of false positive, but they didn't have an increase in the complications that were related to those procedures. So this is just to tell you, like, the relationship between a positive screen test and then the need for confirmation that can carry on their own risks. So in that particular group of those over like 30,000 patients screened, there were 649 patients who had the lung cancer confirmed, but there were other 17,000 that were not confirmed to have the cancer, right? So there is for sure a big population that needs to be screened in order to find those patients who are actually affected by lung cancer. So those are not the only two trials that have explored the rationale and the effectivity of the screening in lung cancer. So there are several others, and they have different designs and different type of population that they include. And in those other trials before these two, the kind of the recommendation was not so clear. It was not consistent amongst all the trials. And then maybe because this is always the reality, there may be some trials that show that this is what should be done, but then from the trial to the reality, there is always this path that needs to be crossed. So the real world implementation, I will say, has been of a low uptake despite the strong evidence. And then the problem will be because not everybody knows that it has been already been proven. And then if you know that you have to have access and like some policies in place to be implemented. So this is beyond just a doctor or a patient. This is more of a systemic program that has to be implemented for it to work. Basically, the limitations on costs are there. And so basically those studies, what have shown is that possibly centralized screening programs are the best way to go. They can improve adherence and outcomes, especially because you have trained radiologists looking after those scans. But then the centralized screening program has to be followed closely to adapt to the particular situation on a given area. As I mentioned, the low dose tomography is effective, but it's not risk-free. So it should be an intervention that is targeted and well managed. And always we have to keep on adding to the evidence that is out there. So if we can actually follow up the patients who have been screened and what are the results from that screening, is always better than just to leave it without any follow-up. So this is kind of a busy slide here, but I will just to show you that, I mean, this is not new. There are already recommendations from several societies about the way of doing screening. So we have, for example, here, the American Association of Thoracic Surgery, whose recommendations since 2012 was to do an annual low-dose CT scan in high-risk individuals. So they call them between 55 and 79 years, who had a history of at least 30 years of smoking a package per day, or the equivalent. And then there is another group that they call the second group, between 50 and 79, who have at least 20 years a package per day. And or the other group is the lung cancer survivors who are free of disease. So just for the continued follow-up for a second primary. So just to mention here, the patients who have had one lung cancer are at higher risk of having a second one, especially whenever it is related to smoking or environmental factors like the ones we were hearing earlier in this conference. Just because the whole anatomy and the whole area from the mouth to the lungs is exposed to those carcinogenics, and it will be more prone to have a second primary as well. So that's the recommendation from the American Society of Thoracic Surgery, and then you have some variation of those recommendations. If you go down, American Cancer Society has the recommendations from 2023, again, an annual base, so every year low-dose CT scan screening for high-risk individuals. The American College of Chest Physicians has it since 2018. The American Society of Clinical Oncology since 2019. And the Canadian Task Force on the Periodic Health Examination has it in place since 2016. So those will be for asymptomatic patients, 55 to 74, again, who have a smoking history of 30 packs per year. And then they will do it, and depending on the results, every year they will continue, or every 3 years, and so on. So we have, like, this is pretty much guidelines. When recommendations make it to the guidelines, like, there is no like too much to ask about it. It works and it should be implemented. So that's what we have there. And now the last part of my presentation, which is what is happening in New Brunswick there. So if we already have this amount of evidence and guidelines that support to have a triage group in place, or a triage program, then what is happening in New Brunswick? So I'm kind of relieved to know that there is actually something happening. Most of you may be already aware there is a lung cancer screening program. They are just in the initial phase of having things clarified and kind of to come up with some recommendations and some program. So there are doctors who are part of it, but there are also people from the administrative point of view and so on. So we have respirologists, oncologists, and basically the people who make the policies in the area, who sit together and try to come up with a way that this applies for New Brunswickers. So what they have discussed so far, and I have to thank here Dr. Amber Swan, who was the one giving me some of the information they have discussed in their meetings. They have come up with some exclusion criteria. For example, people who already have symptoms from lung cancer, they wouldn't go into the screening. They would have to have another pathway, which is the diagnosis pathway. That's still not in place. People who already have, again, like the lung cancer are in treatment, they are also excluded from this. And who are currently for sure in the surveillance plan for prior lung cancer or so on, they also are excluded for this. So this is pretty much asymptomatic individuals who have just the risk factors. And again, the limitation of the age will be between 50 and 74 for coming from the recommendations on the other groups. So that kind of rollout of the plan of screening is planned for 2026. They are just adopting one of the versions that they have to qualify or to evaluate the lung nodules, because as you can imagine, this is not so easy. Like, there is something in a CT scan, and then you have to tell if it's actually something real, or if it's artifactual, or if it's something benign. So to guide the radiologists in our province, they are planning to adopt the LungRADS version of 2022, which is a standardized reporting template that they are trying to bring or adapt to us. So that will be like there are some responsibilities on the program, like the invitation for the first screen, and then the re-screen depending on the reports. They will have to be arranging the follow-up CT scans in 6 months for a probably benign nodule, which will be qualified as a DRADS3, and it will coordinate the repeat scan for the ones who didn't have like a really diagnosis CT scan to begin with. So this is just on the works, but at least there are meetings that are happening, and the plan will be to maybe have something in place for 2026, next year, which is not too far away. And of course, there's a lot of questions that remain. Then, how are we going to integrate primary care to this screening program? Is there going to be a possibility of a nurse navigator looking after those patients who come from different zones in New Brunswick? And if we have a centralized hospital or centralized place to do the CT scans? How are we going to target the CT scan capacity? Like, how many CT scans they can actually do per day, per year, per week? How are we going to work in between the different zones of healthcare and, for example, Vitality and Horizon? And then how are we actually going to have the smoking cessation program integrated as well? So just to finish, because I know I am the last talk before you go to lunch, so I didn't want to make it too long. Just letting you know that a low dose compute like a CT, low dose CT screen is a powerful tool, but needs the appropriate setup. There is hope that a New Brunswick Cancer Network is targeting and trying to at least look for infrastructure for guidelines and patient support. But I will say that we do need to have in place collaboration across zones, and for sure there should be some way of having partnering between healthcare workers, patients, or patients to be, family members, and frankly, all of us who live here, just to create a sustainable program. So it's good that we all get involved somehow in our capacities. So that was all that I have to share with you, and I'm happy to answer any questions.
Thank you very much, Dr. Galvis. So we don't have any question, but I have a little question in mind because I am a respiratory therapist that works in the clinics. And what's happening with our orphan patient? So let's say that they have the symptoms, they are in the criteria group. Um, will they have a letter like they did for colon cancer in the mail, or is there anything that they will be doing for that?
So remember that they what they are currently targeting is the asymptomatic population, people who do not have symptoms and who are not being already worked up, or there is a real concern for lung cancer being there. So this is actually just asymptomatic population who is in high risk, and that's the target of this screening program, right? Like they have to, in order to make it efficient, I guess they have to really narrow the people that they are targeting the intervention towards. So the people, those patients who are identified as high risk and asymptomatic without a primary care provider, probably they will have to be, yes, as you said, invited through a letter, like the way they do for the pap test for everyone, every woman above this age. So there is this invitation letter that they can approach. But I do believe, and as I said, I'm not part of the screening committee, and but I have mentioned to the persons who kind of represent the Zone 3 Atlas that is very much needed to have something along the lines for those other numerous patients who are already symptomatic, are already like beyond just the high risk, like they most likely have a lung cancer, but they just haven't been diagnosed. And then how to have them integrated into the healthcare. That's something that hasn't been addressed, unfortunately. And yeah, so that's all I can tell. That's not part of the screening program that is happening.
Thank you to answer my question. Now, that's where we conclude our 2025 symposium. Thank you for spending your morning with us. And thank you again to all our speakers and sponsor